So Dr. Girish, one of your passions or one of your specialty and your expertise is in oral cancers management, isn't it? So who are these patients and what do they present with, oral cancers?
Yeah, unfortunately in the Asian subcontinent, we are talking about India, Bangladesh, Sri Lanka, Pakistan, these countries, we have a dirty habit, I would say, of people chewing pan masala and gutka.
Tobacco.
Gutka is tobacco. In the West, it is all mainly smoking. It could be cigarettes or pipe smoking. But in our country, one of the sad stories is basically people chew a lot of tobacco. Even in rural India, they chew tobacco as leaves or as sticks. And in fact, that has percolated now into a fine packet which you have seen everywhere. Any corner shop you go over, you see all these packets which are there. That is pan masala. Betel leaves and arecanut, which is basically packaged very well. And unfortunately with that, tobacco is also added. And that is basically gutka. So chewing tobacco is, I would say, the biggest culprit for mouth cancer. And this could be even young. I mean, you know, when we were training for 40 years back, at that point of time, we would see only cancer in the older age group, right? 40s, 50s. And today, youngsters as young as 12 or 15, they start chewing tobacco. And there are certain precancerous conditions which we see. Submucous fibrosis is one. And that can become cancerous. So 25 to 30% of all cancers is, oral cancer today.
So you're seeing a shift in demographics, age demographics, that it's becoming younger and younger.
Yes.
So this is because of they're starting early.
Yeah, I mean, these people continuously keep chewing. I mean, even in the village side, when you're doing some work, normal courts, domestic courts, they have, this betel leaf with arecanut, and they add tobacco into that, and they keep it in that side. So continuously the toxins of that is working on the mucosa, on the tongue. And because mouth cancer is not painful in the initial stages, there is a small white patch or a red patch, and then a submucous fibrosis is where your entire mucosa becomes very thick and leathery. What is soft and supple and pink becomes whitish and leathery kind of thing, and they become intolerant to spicy foods, and they can't open their mouth at all. Gradually the mouth opening reduces. So this is a precancerous condition. This, if the habit is continued over a few years, generally becomes cancerous. So,
is there a male-female differentiation in this?
Actually, I think it's almost common, maybe 45-55%, males probably 55% and females 45%, I would say.
And what do they present with?
It could be a small ulcer, a painless ulcer, or a growth. That's what. And we see them in advanced stages, T3, T4, stage 2, stage 3 kind of thing. Because cancer in the initial stages is completely painless. They don't have any symptoms. They ignore it. This is the problem. There's a small ulcer, a small growth, it'll go away. They tried different kinds of gels and they just leave it till you see a huge problem, a big growth. And that's where we are seeing very advanced cancer. Or sometimes they come with even a neck node. So it is already spread into the neck to the secondary area. So that is the problem in India. We see cancers at a very late stage.
And when they do present to you, how does the workup go?
Immediate good clinical examination. We do all the basic blood workups. Diagnostic thing is a biopsy. So first and foremost is what we do, a biopsy. Confirm that, then a scan. It could be a CT or an MR or a PET scan. Today affordability is there and we have all these scans. So we just make sure that there is no spread of the disease and then we go ahead with the treatment.
So to diagnose this, as you said, a biopsy and all these scans and things, do they need to go to some specific centers or can it be done at a more lower level of a hospital?
Yeah, I mean, Actually, if you really look at it, the best thing is self-examination, like how we have in breast examination, and that's what from the association I've been, as the secretary of our national association. This year, actually, we took on a big project of prevention, early detection, and early intervention. And we came up with videos where you can do your own self-examination of the oral cavity. Everybody brushes every day. Twice a day is what we recommend. So at that time, just look inside the mouth, right? And when you go into your dental office for a checkup, we recommend every 6 months or at least once a year to get your teeth cleaned. At that point of time, a dentist should do an oral screening procedure for cancer. And this is very important because a lot of precancers can be picked up very, very early. A small white patch or a red patch or a small ulcer which is not healing for more than 3 weeks needs to be investigated further. A simple biopsy can be a lifesaver for them. So I think you don't have to go anywhere but just your medical doctor or your dentist, when you go in for checkup, ask them to do an oral screening for cancer.
Again, as you said, the demographics is such that majority of the patients who would end up with the cancer are unlikely to be examining their own oral cavity and things like this, isn't it? They're having their tobacco all the time, as you said, even when working. So where is it?
And this is where the government is doing a lot of work. In fact, they have, I'm very happy today that there are zones where, smoking is banned in most of the public places. That itself is a big step. And I want them to even ban chewing of tobacco because this is killing people. At the end of the day, there is a big tobacco lobby. You can't help it. All over the world, this is a problem. But we as medical practitioners, we believe that this is something which can be preventable. And that is where I think a very strong step you need to take in. And maybe ban it, although they say it cannot be sold for people, less than 18, and you can't have these corner shops selling tobacco, 300 meters from any schools. These are very good, definitely the government is doing. But I would say, and you go to any movie, you see a beautiful, story which is put on every movie hall, where the first thing is basically somebody with a nasty cancer and how lives have been lost because of that and how the family has been devastated.
So education and awareness.
Education is the key, I think. And we are all doing it as a specialty, as maxillofacial surgeons and our dental colleagues and our medical colleagues and oncology, specialty per se. We are all bringing in a lot of awareness campaigns because prevention is the key. And that is where. But in addition to prevention, early detection, early intervention can be a game changer.
So for this early detection, are the doctors at PhD levels or initial screening people, are they all educated enough or are they aware how to pick these things up, or are you finding some lacunae there which they need further training to pick these things up early?
Yeah, I think so far people wouldn't do this on a routine basis, but 3 cancers today the government itself has given a push. One is breast cancer, the other is cervical cancer, and the third, I'm happy, is oral cancer. So the national mission itself is basically on prevention for these things. So everybody is actually undergoing these kind of screenings, and that is very, very good. So definitely there is a push for training all doctors and healthcare workers. It doesn't have to be a doctor.
Absolutely.
And today we have lots of apps which have come in today. You can actually take a photograph and then send it to different apps, and we would be able to actually say, hey, this is high risk or this is basically normal. Come back, after some time. So it can be done anywhere remotely too. So there is a lot of technology which is coming in, which is helping in diagnosis too.
It is, isn't it? Isn't it? So what is the burden now in the general public?
Almost 1 lakh cancers every year is being diagnosed, and people are losing lives to that extent, I would say.
All over country?
In our country, 80,000 to 1 lakh people are dying every year because of oral cancer. This is the Global Cancer statistics, what I'm quoting actually. That's a huge burden. And if we really look at the numbers which are there, it's even bigger. And unfortunately, the ones which are not detected is even more bigger. And this is where we need to do massive screening camps for oral cancer, or as a matter of fact, any cancer.
And these Biopsies, what you said, do they need specialist centers or can they be done at a lower medical center?
You have certain easier things which we are, like how we do pap smear. Same thing like that, we have something called as a brush biopsy. You can just take a swab kind of thing that has got kind of, you know, abrasive thing. So all you need to do is just a bit of scratching and then send it to the lab and they can actually detect it. So there is definitely a possibility that it can be, you know, as a nationwide project where people can themselves do it and send it, and then we can actually see who are the high risk groups. But I think the most important is self-screening, and that is probably the key. Every time you're brushing your teeth, have a look inside. If something is not normal, don't hesitate to go and ask for help, because this could be something more sinister than what it is actually. And if it is there for more than 2 weeks, don't sit on it. A small ulcer or a small growth, go to your dentist, go to your physician, and we are here to help the public. That's what we are.
And so, let's say you've got this biopsy done and you have a positive result. What does positive mean? Meaning, are there different varieties of cancers? What are we looking at?
As I said, there is a whole spectrum of cancers. First, you have the precancerous conditions, and then you have the dysplasias, and then you have the cancer. So that entire spectrum, it depends on where you are, right? Even in cancer, it is early, middle stage, and then late stage cancers. If you are in late stage cancers, treatment is very, very difficult, I would say. I mean, even though it is difficult, the outcomes are unpredictable. The 5-year survival can be, questionable at that point of time. But if it is early cancer and precancerous conditions, we intervene very early. It could be a simple laser excision, can be done under local anesthesia, sent to the lab, and then you can just forget about it, and then regular follow-ups is necessary. If it is slightly more, then we admit them into the hospitals, do a more extensive procedures, multimodality kind of treatment, surgery, radiation, chemotherapy, immunotherapy, all these things are there today. And this specialty has grown so much today. Quality of life also can be very, very better approached.
As far as investigations are concerned, biopsy is one of the things.
Correct.
What other investigations would you do?
Generally, we do a scan. It could be a CT or an MR. But in addition to that, specifically for cancer, we actually give a dye, a fructose dye. So that is a PET scan. And you can actually see which are the cells which are multiplying. So that way you can detect cancer much, much earlier. It could be even a spread of a cancer can be detected. So a PET scan probably is very, very useful. So those are the other specialized investigations we do.
So the availability of these investigations?
Oh, in India it is there. I mean, it is not a problem at all. I mean, there are private sectors as well as, the government sectors, and in institutions you have, dedicated institutions for oncology today. There are lots of them across the country. So we have actually invested a lot on, although the burden is huge, but today we have some fantastic institutions doing some cutting edge oncology work, I would say.
Okay.
So there is facilities available.
That's nice.
I feel it's the hesitation from the patient not accepting that it could be something nasty. That is something, and that is where our public health education probably is the key.
Then these specialized centers, are they more urban centric, or even rural population have access to these things?
I think a hub and spoke model is probably the best way. So detection can be done anywhere else. And today we have seen district hospitals also actually identifying, doing a biopsy and then sending it to either a government-based organization, or it could be a private or a charitable organization which is actually doing exclusive oncology work. So that is the way forward, I would say.
Okay. In the journey now, for the patient, they've had self-screening or they had screen, had a biopsy, positive, we've done the other investigations. Now what? What are they looking at? Treatment-wise?
Treatment-wise, first and foremost is what we do, counseling to the patient. Need to really, at the moment somebody is diagnosed with cancer, it completely drains you off. And I think the most important thing is basically bringing in that positivity to the patients to say that, hey, we are here to help and you can actually win if you have a very positive attitude towards treatment. So that takes a lot of time, I would say. And once that is there, then we run through a multidisciplinary meeting where all specialists, be it surgeons, radiation oncologists, medical oncologists, immunotherapists, and including psychiatrists and, everybody is there, dietitians, speech therapists. So we all sit together, we counsel the patient, and then we come up with a treatment plan. Give options to the patients, which are the best way forward and what are the other things which they can go through. And then once we are in consensus, then we go ahead with the treatment.
Is it always surgery?
No, I mean, many times, ideal if you talk about oral cancer would be surgery followed by radiation if necessary and chemotherapy and immunotherapy. Chemo and radiation is probably the second line of treatment, I would say, because once you have bone involvement in the mouth region, lower jaw, upper jaw, or in an advanced case, then it is much better to do surgery followed by these two modalities of treatment.
So you give a margin and do a wide resection.
I think the most important thing is to give a good resection. The best is the first surgical kind of procedure which we do, giving very good margin, 1 to 2 centimeters completely. And even while doing surgeries today, we have frozen sections. That means that the pathologist calls up and says, hey, your margins are all clear. If there is close or if there is slight involvement, then we go in and excise further. Because invariably today we are also doing reconstruction and we don't want to transfer tissues from other parts till we are sure that the cancer is completely taken out.
So you do these reconstructions at the same time or as a second sitting?
Majority of the times today, we are doing reconstructions at the same time. So unless there is a medical indication where there is compromised health, we want to do the procedure very quickly. So it's only resection, then we do this reconstruction as a second stage. But 95% of the times it is always surgery, which is ablative surgery followed by reconstructive surgery.
And how often would they need further treatment like chemotherapy, radiotherapy, you said?
Again, it depends. Many a times if the nodal involvement is there. See, the thing is from the first stage where it is inside the mouth cancer, it spreads into the neck. And at that point of time, if the neck is involved, then it is basically an indication for radiation. Younger the age group, then we give concurrent radiation and chemotherapy together. But if the margins are close or if the thickness, the depth of invasion is very deep or the nodal involvement where there is extranodular spread or extracapsular spread, what we call as, at that time it's a clear indication for radiation. There are criteria on which we follow it up today.
Again, I assume these things are very specialized and localized in urban centers. Are we behind as compared to other advanced countries or do we have everything that we need in the country?
To be honest, I think we are more ahead.
I'll agree with that.
To be honest, Dr. Prasad, I mean, I trained in UK and I keep traveling across, every other month I'm in different parts of the world. And my passion is to go into every hospital there and see how they are treating. I think today we are in that cutting edge where India has leaped forward, I would say. It's not grown. In medical profession, we have leaped. We have just jumped further. And, the training facilities have been fantastic here. The infrastructure has been very, very good. I operate even in NIMHANS where that's the neuro center. We have intraoperative MRI. When you can wheel the patient when you are operating and get the clearance done when you are doing major skull base tumors there. So you can see actually, not many facilities in the world have that kind of facilities there. Navigation surgery is there, robotic surgery. Today, robotic surgery is coming in almost every hospital where I work. So we are now with cutting edge technology. And the same thing what happens anywhere in the world, we are actually doing. And I think ultimately, my dream is that we should be coming not with protocols which are coming from Sloan Kettering or MD Anderson or Marsden Hospital, Royal Marsden in UK. It should be from India. Tata Memorial Hospital or Shankar Cancer Hospital. Protocols is what people should be following because we have the numbers. We have the numbers. And today, with software available, you can actually put all the database and you can actually analyze how things are. Outcomes itself can be. One of the problems what we used to have was data collection and reviewing auditing all our, outcomes and things like that. But today we are doing that, to be honest. And I think we are one step ahead of most of the countries, I would say.
I agree with you. I think we should start publishing and we'll start making up protocols so that rest of the world follows suit.
That's my dream. A lot of us, we feel that, and from our association also, that is where we want to bring in protocols which can be followed across the globe.
That's right. So there is no need for any of our patients to be going elsewhere outside in the country to receive treatment?
That era is almost gone. I would say it's the other way around, I would say. Today, we are getting a lot of patients from different parts of the world coming and getting the treatment here. That itself indicates that we are growing or we have grown. And two reasons for that. One is because technology is very good here, and the surgeons and the physicians who are here are very well trained. They're doing some really, really good work. The second is because affordability is again, I mean, medical treatment is still very affordable here compared to the West, I would say. So that is why I think a lot of patients from different parts of the world are coming here.
Yeah, that was my next question, in fact, affordability. How affordable are these treatment options, including surgery, radiotherapy, chemotherapy? Can the general public access it?
Yes. India has got some kind of, nobody is denied treatment, let's put it this way. To be honest, even though it's so chaotic, but there is some ways in which you can actually get, everybody is given good treatment here, I would say. And this is what I've observed. It's not that I'm just saying like that. There are a lot of charity organizations. The government organizations are fantastic. The government has spent a lot of money today in upgrading the facilities what are there. Although there is a huge waiting list even there, but the kind of work which is being done there is very, very good, right? So that is something, and that's almost free. Then when it comes down to corporate hospitals, again there the infrastructure is fantastic, but cost is quite high there. And that's where the insurance sector is coming in. So there is a big leap in the level of coverage which has happened in the insurance sector. So a huge number of people are taking in insurance. Then you have the charitable organizations in between the two. It's neither government nor it's corporate. So you have, like where I operate, Sri Shankara Cancer Hospital. That's a kind of charitable organization where the poor gets free treatment or very subsidized treatment, while people who can afford can actually pay for even them, I would say. It's like that. So you have the special wards and you have the deluxe wards where the cost is much higher, and that's intentionally kept so that that compromises for somebody who can't afford.
It offsets.
So it's like, you take it from Peter to pay for Paul. That's exactly what we are following in different places. And there are some charitable organizations who are coming in and saying, we will fund them. So many treatments per year is donated. So there is a lot of, ways in which people are actually getting the best treatment in the world. I'm not just saying treatment, they get what is an accepted norm anywhere in the world.
Very nice. Very nice. Now coming back to the patient's journey, so they've had this surgery, radiotherapy, chemotherapy, whatever that's necessary. What are they looking at? What's the prognosis in terms of their general outcome?
Yeah, I mean, as I said earlier, if it is early detected, then it's almost curative. There's no problems at all. It's very unfortunate if the disease comes back, I would say, because we are, as a body, we are passionate to give good margins, to take the disease out completely, and then give further treatment if need be, depending, as I said earlier, radiation, chemotherapy, and things like that. But if it is an advanced disease, unfortunately, they come to us in stage 2, stage 3, T3, T4, huge fungating lesions. They do pretty bad. I mean, 5-year survival for that, or sometimes even 3-year survival is pretty bad in such cases. So we see the disease coming back very rapidly. You would have done the surgery, given radiation, given chemotherapy, sometimes even immunotherapy. In a couple of months, you see the disease coming back. So the biology of the disease is something which we have still not understood, I would say. In which group of patients you get recurrences or spread, and unfortunately they do very badly. The younger the age group without habits, many times when they get the disease, they are more aggressive in terms of biology of the tumor. So it's very unpredictable, and that's why my message is detect it early and intervene early.
I'm sure this must be a significant impact on the patient's life himself and the family as well, both physically, mentally, emotionally, financially. What support is there for these patients and the relatives, for the family itself, in the community to take care of their well-being?
I think one of the things in India is your family support itself is fantastic. I mean, the extended family, what we call. I see even when we see our patients, first time when they come in with whatever disease it could be, not just cancer. In a waiting area, it's not that only that patient and the spouse is coming. You see the whole family would have come. There will be at least about 8 to 10 people, the brothers, sisters, in-laws, everybody is there. So I think the extended family, I would say, is the biggest support, right? That itself is number one. But when it comes down to medical side, the kind of support, today we have integrated the treatment in such a way that it's a team approach. So we have, psychiatrists or psycho-oncology is another thing, which a good friend of mine has started that and started even training people on that. So they are the people who come in and really give you that kind of assurance. But as clinicians, we ourselves do a lot of counseling. I mean, every patient I counsel them. I tell them, look, what has happened has happened. Don't think about why it has happened. The biggest problem is for people to accept that, why me? Why have I got cancer? So I said, that has happened. Now let's accept it. Once they accept, then let's look at how we can completely cure you. And that is where I try to infuse that kind of positivity into them and say, now you need to shift your focus and say how I can do myself better, how I can come out of this disease, how I can get back to normal lifestyle, how my quality of life can be better. So that is where we as clinicians, we bring in a lot of counseling because we see them so often. So it is very, very important that we do that.